accommodate different clinical situations. Then also shorter implants were developed, ultra short implants, and so on. And I will show you how to do that. Before we go into that, I also want to show you, some of you might be on Facebook, and I said education is very important. And I have established about 2 years ago, when I was at Harvard, my second time sabbatical, I got exposed, a lot of young postdocs, all on Facebook, so we said we established a Facebook site. I call it the Buser Implant Team, and there we share a lot of knowledge, and currently we have about 5,000 followers, and it's increasing every week a little bit. And if you want to be part of this Facebook group, when I retire, I'm gonna post every week one post, a case, a new publication, a recommendation, and you will not get any non-evidence stuff. It will be very solid educational information. And the QR code there is very easy for you then to find out. Ask for participation, I'm gonna approve you, and then you're in. Good, okay. What are the criteria for implant selection? When are we using standard diameter, small diameter, or narrow diameter, wide diameter? When do we use tissue level implants? When do we use bone level implants? Short implants, ultra short. I will give you a nice review how I do it. Of course, this is personal preference. Others are doing slightly different, but there are some principles behind it, and that helps a lot. Okay, so the first question is, of course, tissue level implants, bone level implants. That is related to the Straumann implant system. And I've showed you, see that we have these implants with a machine neck and a micro rough surface inside the bone. They're often called tissue level implants because then you can bring the shoulder further up to the oral cavity, so it's above the crest. And tissue level is probably not such a bad expression. Okay, so these are the implants we are having in the whole assortment from the tissue level, and you see when they were developed. So the original shape, 86, I was part of that development in 1985. Professor Schroeder came to me and said, we make a new implant system because we have had, before that Straumann had different prototypes, hollow cylinder implant, the TPS screw, all of them one-piece implants. Implant and button, same piece. None of them were two-piece like Chronomap. So that was then the development. But then you see how we started to come up with a narrow diameter, wide diameter, wide neck implant, narrow neck implant, and then later on the so-called SP version with a short neck. And then in 2011, the so-called NNC, narrow diameter implant made of rock solid, which is an alloy material, titanium, zirconium alloy, stronger material. And then of course you have the bone level line. The first bone level came out in 2008. We started to use them in 2005. Standard diameter, 3.3 millimeter, then bone level tapered. And now you might have heard that IDS in Colonia 2 weeks ago, the BLX implant was launched, which is another bone level type implant. How do we use them? So, 5 years ago, we used about 75% bone level implant, tissue level implants, 25% bone level implants. 2 years ago, when we analyzed again our patient pool, actually the percentage of tissue level went up again. So today I use the bone level implants, very limited for a specific application. I use it in the aesthetic zone, I will show you tomorrow, and for single tooth replacement, excellent implant.
I never used them so far in the posterior. I did so 10 years ago, and I was not happy with the results. So I'm using there strictly tissue level implants, because we have the neck with the machine surface, also the hybrid design, what I mentioned before. And when you look at it, then you see that we have here the diameters. The standard diameter, 4.1 millimeters, about 50%. And then the wide diameter is about 25%, and the narrow diameter also 25%. That's mainly the NNC tissue level narrow diameter I will show you. And we started to use the 2.9 millimeter BLT for very specific cases, not big numbers. Now last year I got, I think, 5 patients, 5, but beautiful indication, beautiful, mainly single tooth, very small anatomy. And of course, now when we look into the more details, you see here how it's used. So that was in 2017. I have not received yet the 2018 numbers, because to go through the whole list we have to check very carefully the statistics, exclude all errors and mistakes, and then analyze. And we are in the process to do that. So 2017, more than 80% tissue level implants. Mainly the S version, the 2.8 millimeter machine neck, not the 1.8. I believe in the future Straumann should put them together and have only one machine neck. That would simplify for us. And then I would do it probably 2.3 or so, something in the middle. Not 2.8, not 1.8, 2.3. That would probably be a very good compromise. But we'll see if Straumann comes up with that. And of course I would love to have also the bone level implant, the machine neck type. And I know the prototypes are in the process to be worked out. Okay. And then you see here the percentages. So when we compare them in a single tooth situation, tissue level, bone level, you see here when you have a single tooth gap, and that is the topic tomorrow. Then you see on one side is the tissue level implant, on the other side is the bone level implant. That is the indication where I have a strong preference for bone level implants, not in every case, but most cases. Why is that? You see, the bone level implant has the micrograft surface all the way up, and this is a platform switching implant. Very precise fit inside, and then you don't lose bone at the outside. Whereas when you have this implant here, as you can see, you get here a saucer. A saucer, that means a little remodeling, which is not pathological. This is the reaction of the biology. And then it's a machine neck, that's fine. So in a single tooth situation, this will not harm the papillas. But of course, on the buccal aspect, you maintain better bone with a bone level implant. I will explain that in more details. Here you see then how it looks in the radiology. See that tissue level implant with a little bit of remodeling, bone level implants with almost nothing. Good, that's a paper by Vivian Chapuis, 2016, our group where we compared. And you can see that in a single tooth situation, 2 patient populations, one with tissue level, one with bone level. And when we analyze the data, you see, you can analyze here, that's here, the so-called DIC. Where is the peak compared to the implant shoulder? And on the facial aspect, it was measured on cone beams. The situation was more favorable for bone level implants. Better maintenance of bone for soft tissue contour. And you see, here you see the numbers, facial DIC. See, beautiful. I will show you tomorrow these cone beams in more detail when we talk about the long-term data. 10-year follow-up cases in this contour augmentation. So that's why we have a preference for bone level implants for aesthetic single tooth replacement from first premolar to first premolar. It's about 20% of patients. Good. When we do bone augmentation in these sites, you see this is a tissue level implant with a 1.5 millimeter healing cap. Bone augmentation is done to the healing cap. When we do a bone level implant, we always convert the bone level implant into a tissue level with a healing cap of 2 millimeters. So we can also augment to the healing cap. Very important to get a peak of the bone coronal to the implant shoulder. This will be discussed tomorrow in all detail. Okay, and here you see the two applications. Bone level implant, aesthetic single tooth replacement. Beautiful results. Excellent. You see also how well these patients clean. This lady here is, I think, 8 years down the road. The other one is already more than 10 years. It's a small diameter bone level implant. Very nice treatment results. Okay, when standard diameter, wide body and narrow diameter. So the wide body diameter is used when we have to use shorter implants. So when you have implant sites in the posterior mandible, in the posterior maxilla, often the height is reduced, but then the width is increased. So when we have a reduced height, I always check how is the width of the crest. Is it 7-8 millimeters? These are mainly first molar sites. And then the question is, can I use a wider diameter implant? So wide diameter short implants compensates for the anchoring surface. So when you have a standard diameter of 10-12 millimeters, that's no problem. But when you go to short 8 or 6 millimeter, often you can compensate with the diameter. Then I always compensate for it. That's very important. For that you need a lot of bone crest. Because keep in mind, we want to have a 1.5 millimeter thick facial wall. So a first molar, tomorrow we talk about that when we talk about sinus grafting. First molar in the maxilla, the ridges are very wide. Height 3-5 millimeters only. Then there is no chance to have standard placement. Then I always use wide diameter implants and use them probably at 10 millimeter in the first molar side. Okay. So the advantage of wide diameter implant is clear. You can increase the anchoring surface of the implant to take the load-bearing capacity of functional loading. What happened to my screen here? Can you bring it back? So I see, I always have to turn around. Now when we go for the tissue level implants, you see these are all cases we treated in the 1990s. So you see all the different scenarios. So you can have a single tooth implant with a standard diameter. You can have one with a cantilever. We do very often. When we can bypass a bone augmentation procedure, then we add a cantilever, well documented for up to 10 years now. Then we have often 2 single implants non-splinted when they are sufficient in length. But we can also have, of course, 2 splinter implants and the cantilever again. When we go for short implants, as I will show you later, we often splint to compensate for the short implants. We can have 2 implants and a 3-unit bridge, of course. We can have 2 implants and 4-unit bridge. I have cases with 2 strong implants, 5-unit bridge. That works. So it can be the posterior maxilla, mesial cantilever for smiling. Very good. That works very nicely. So a lot of flexibility for that. Very important, as I mentioned, when you have a situation that is all posterior mandibular, that will be the topic in the afternoon. Then we check very carefully when it's very on top, very narrow. I check them with a cone beam to see is the crest increasing like this. How much do we have to shorten? And then we put the implant deeper inside the bone to bury the SLA surface subcrestally. Very important. So you can estimate how much reduction in height is necessary to get these implants inside the bone and have on both sides sufficient thickness of the bone. I will explain that in more details then in the afternoon. Okay, the consequence when you put implants deeper will be an increase in the crown to implant ratio, but I will show you in the afternoon that's not a risk factor. Don't pay attention to that. Okay, now narrow diameter implants. The narrow diameter implants are 3.3, now even 2.9 millimeters, and that's not finished yet. We are just starting a big study in Bern with 4 narrow diameter implants, 2.9, to support dentures. So we'll see if that works properly. Okay, so the 3.3 millimeter. The 3.3 millimeter implant has been used since 91, and that's that's more than 20 years now. It was developed for crests a little bit smaller in diameter. Okay, so the advantage of that one, often you can reduce the morbidity for the patient. When there is, let's say, a 6 millimeter crest, and you want to keep on each side 1.5 millimeter, then you cannot place a standard diameter because you get very thin buccal wall. Then when I see I can do that with a 3.3 millimeter implant, then I don't have to do bone grafting for that patient. That's a big advantage. Sometimes, when there is not enough bone and you take a small diameter implant, you have a chance to do the bone grafting then with a simultaneous GBR and not with a staged approach. Instead of having 2 surgeries, it's only 1. That's a big advantage for the patient, and so on. And when we go for small diameter implants, I always use rock solid implants, a stronger material. Is it on the market here? I hope so. Rock solid. This is, I will show it to you, this is titanium zirconium, 15% and 85%. The mechanical property is much stronger, about 30%. So I have not seen any fractures with rock solid implants. I use it mainly as an NNC, which is an excellent implant. I love to use NNCs for premolars, sometimes edentulous patients and so on. Here you see that's the NNC implant. This is a rock solid implant. It's a titanium zirconium alloy. And it was developed in 2010. Thank you. Okay, well, I get my picture back here. Good. Okay, it's extra strength. We use it in borderline cases when there is, let's say, 6 millimeters of bone, and very nice implant also for elderly patients. Elderly patients don't have a very strong chewing force. So I even use it for first molar replacements, but then add there a premolar on top, not a molar of course. It has to be cleansable. Okay. In 2017, as you can see here, 25% of our implants we placed were narrow diameter implants. I think 20% were NNCs, 5% bone level 3.3. The bone level 3.3 is used for lateral incisors often, and NNC is used mainly in premolars and molars. Here you see such an example. So you see that the patient had a very narrow crest. It was analyzed with cone beam, and I saw we have to reduce 3 millimeters in height, and then we get a better shape. So it was very narrow on top, then we take it down like this, so you get about 6 millimeters. And then we placed, for the first implant, we placed a narrow diameter as an NNC implant. And the second one is a standard diameter implant in the first molar side, and you see how much we placed the SLA surface below the crest to avoid too much resorption. And that helped us to overcome no bone grafting necessary, 2 months of healing, restoration in private office. Now this was restored in private office. The dentist did not follow my advice. I told him to split the 2 crowns. He did not. I hope this is not going to pay negatively, because the second implant is a short implant. So I have much better confidence than when we split these shorter implants. Okay. Here you see very typical application, elderly patient. She was 89 years old, this lady. She was presented in a treatment guide, in this treatment guide on elderly patients, about 3 years ago published. And when the patient came, I know this lady for many years because she got in the maxilla both sides sinus elevation about 15 years earlier. I gave her a full rehabilitation in the maxilla, so she's fully with natural teeth and with implant supported prosthesis, and then she lost a bridge. So the bridge was lost because the premolar there had a problem. So the referring dentist took the premolar off, sent the patient back. Then instead of doing an implant placement with a GPR procedure, we analyzed the case very carefully, had to reduce the height. I will show the detail again later on. And then we put in an NNC, small diameter implant, and another tissue level implant in area 6. And then we restored the patient. Then non-submerged healing, and we got the implant restored. You see this splinted crowns, meso cantilevers, like a bridge, an extension unit. And the patient is 4 years down the road. Now she's 93. She's doing very good. She still drives a car. Home care, yeah, okay. You can see she doesn't care too much about old fillings or old composite fillings. She wants to chew. So that's her emphasis. These patients don't care too much about aesthetic outcomes. When they have old fillings, they don't want to have them replaced. But when they are using bridges and they cannot chew anymore, then they won't have a treatment to get the chewing back. That's what these patients do. You see the splinting, a 10 millimeter, 10 millimeter, and the cantilever. So, then this is the BLD 2.9, very small. I will show you tomorrow the case, how we treat it, when we talk about GBR in mandibular cases. That's how the patient came in. We put then a BLD, you see very narrow gap. And you see then the implant was done in conjunction with a GBR, minor GBR procedure, 2 months of healing, restoration, private office. This is the 1-year follow-up. And you see the implant is in the middle. And you see beautifully, very healthy. Patient very pleased. The 2 adjacent teeth have little recession. Patient doesn't care about that, but she wanted to have this single tooth gap in the mandible fixed. So that's a very nice implant. I have done about 10 implants like this in the last 3-4 years. So short-term experience, short-term. Okay, now what about the short implants? Short implants or ultra short, you could call it. I call short implants 6 millimeter implants. Ultra short 4 millimeter implants. And These are not new implants, the 6 millimeter short implants. They go back to 1986. I show you my first patient I treated in 1986. But the ultra short implant goes back 5 years now. I do it with enthusiasm. When I want to bypass a sinus flow elevation, I use it 3-4 patients a year in the posterior maxilla. That is how we do it. When to use these ones? So short implants, they play an important role in the posterior sides, mandible and maxilla. They are important for 2 reasons. One is, often you can avoid sinus floor elevation. That's a major progress for patients, when you don't have to go into the sinus and do a bone augmentation inside the sinus. This is a big advantage for elderly patients. When you have a patient with anticoagulation therapy, so the blood coagulation is disturbed, I'm very careful to do a sinus floor elevation. I have had in my career one patient who got a bleeding following sinus elevation because of an anticoagulation problem, and it was a major complication. Patient didn't stop to bleed for hours. Then finally we ended up in the intensive care unit and had to do a tamponade through the nose, and then it was ugly. I said, never ever again I take that risk. I learned a hard lesson. So then I rather prefer to use an ultra short implant. The same is in the mandible when there is not enough bone height on top. So I try to avoid, of course, nerve injury. I'm very proud to say I've done so many surgeries, never injured the nerve. And I don't want to change that. I have seen in my department 3 nerve injuries in the last 20 years. That's not much, because in 20 years we treated more than 10,000 patients. But these 3 nerve injuries have been a pain in the neck for the patients and for us. Very disturbing. Patients complain heavily that life is changed, and when you get anesthesia here, or even when you get a hypoesthesia, or when you see that they feel like it's constantly moving here, and that's really bad. So do everything not to have these complications. So short implants need special considerations. They have an increased failure rate if you use them non-splinted. I will show you the latest data. So you need to consider these aspects. Splinting, you need to consider age of the patient and the bite force of the patient. And you need to consider the bruxism. Do you have a bruxing patient as a risk factor? So the bad is you see a very strong man, a strong lady, age 60 or so, with bruxism. Then you be very careful with short implants. You get them disintegrated very quickly. Okay. So when you look into the posterior maxilla, how many implants we are placing? See, many implants. In 3 years, almost 900 implants in 3 years. So, and this is the analysis from 2014 to 2016. See, and though in this region, this is a topic tomorrow then, you can either use short implants, or you do sinus for elevation, simultaneously or staged with the so-called lateral window technique, or you do then the sinus elevation with the transcranial ossotome technique. I will show you tomorrow how often we do what. Today now we'll just talk a little bit about short implants. So this is then the decision tree, how to select. It all relates to how much bone height is available at the implant site. Is it less than 4 millimeters, then you cannot place an ultra short implant. For an ultra short, you need at least 5 millimeters. and so on. I will come back to that tomorrow. That's tomorrow the topic. This is, by the way, my first 6mm implant I placed in 1987. You see the fidelity with the restoration was really bad. It was done in private office by the referring. It was of course not screw retained, it was cemented at that time. But you see that this short 6mm hollow screw implant. See, I had a patient and I saw the radiograph, only 7mm of bone height. So then I sent an 8mm implant back to Strong, asked him, can you please cut off 2mm? I needed a 6mm implant. I got it back, sterilized it, put it in. The patient unfortunately passed away 15 years later. It stayed there for 15 years. So he passed away early 2000. So he would be today more than 90 years old. But that is just a historical radiograph. So when we talk about 6mm implants, you see, these are the papers I refer to. That shows you that when you do non-splinted 6mm implants, the failure rate is increasing. And the failure rate increases by disintegration, it's not by infection. The implants are not large enough in the anchoring surface to maintain the functional loading. And I show you here, one paper is from 2016, one from 2017, one from 2018. And when I give you the table here, you see, one is from Italy, one is from South America, one is from Zurich, Switzerland. And you see the failure rates are between 9 and 9% at 5 years. That's a much higher failure rate than normal. So non-splitting I would not do in a normal patient. So then we split it to other implants. I would talk about that in more details tomorrow when we analyze patients in the posterior maxilla, and that's very important. So here you see two of these cases in the maxilla. Bypassing the sinus floor elevation procedure. So on both sides you see 6mm implants, but splinted. So this same patient actually, bilateral. I did it computer-assisted, flapless. Patient was a heavy smoker, so I didn't want to do sinus elevation because of the smoking problem. A very good friend of mine. And in the meantime, he starts to diminish the smoking. I see him every 6 months and I say, please stop. And he's getting close to 5 cigarettes a day now. So it's getting better and better and better. The implant doing fine. I have not seen him last year for a follow-up, so the radiograph is from 2017. 4 years follow-up, so actually very nice. Here you see one of the ultra-short babies, 4mm. This is also 4-year follow-up. I have a couple of patients like this, 4mm in the first molar, 8 or 10mm in the second premolar, and then you split it. And with that, you don't have to do a sinus elevation procedure. That is a big advantage for the patient. But I have to confess, we don't have any long-term data, up to 5 years now. You see, this is a 4-year follow-up, but small number of patients in our department. We do about less than 10 per year. I think I did last year 4 cases myself. So we have to see. So I think when we have enough 5-year cases, we do a retrospective analysis, always in splitted configurations. And I'm sure the implants are doing quite okay. Now, often these are elderly patients. That means they don't need to have a 30 to 40 year follow-up because they're going to pass away before that. So when a patient is 85, then of course you can say, okay, let's hope it will last for the next 10 years because then the patient's life will come to an end. Hopefully with these implants in place, no problems. So that's the whole strategy. Another very interesting case is this one here. You see, when patients get very old, very elderly, then I do sometimes compromise that I even use a 6mm implant for a single tooth restoration. This is the most interesting patient here. You can see that's the patient roughly 5 years ago. Patient was sent back to private office following extraction of the first molar. This patient has in the mandible an implant from 1987. So this implant is in place 32 years. And then she got this hollow cylinder implant here in 92. That was just about a year before we stopped to use those. So that implant is in place 26 years. And then she has on 2 other locations implants. And she got back to us with this single tooth situation. And I took a radiograph and I saw that when we put an implant straight, we get into the sinus. When we bend it over a little bit, then we can bypass the floor of the sinus when we use a 6mm implant. Then I told her, look, I'm not going to do a sinus dilation with you. You are 87 years old. She's in good shape. But 87 is 87. So we're going to use a short 6mm implant, bend it over, single crown. These patients have very slough musculature. They don't bite very strongly. That's why I think you can take the risk. Interestingly, I will show that tomorrow to you. I have to ask to get the radiograph. A year ago, she comes back. Half a year ago, first premolar extracted. That's the premolar you see here. A lot of decay. And asking, can we do something with that premolar? So then I said, yeah, too bad that the referring dentist took it off without socket grafting. So we let it heal and hope that we have enough bone then to do flapless placement for the first premolar. And I let it heal for 4 months and took a co-beam and saw, yes, it's enough. So we did a flapless placement in BLT 2.9 to have flapless non-grafting. Patient will turn 90 years now this year. So now she has 6 different implant surgeries: hollow screw, hollow cylinder, standard diameter, 6mm flapless, BLT 2.9. So she has the whole history of implant development over more than 30 years. A unique patient. I told Dr. Shapley we're going to put it together as a case report. It documents the progress of implant dentistry in one single patient. And she's very strong in her mind. Her body gets really older. She's walking slowly, but she's still the same character and very strong in her mind. Here you see the 4 years follow-up last year. The tooth was still in place. In the meantime, has been taken off. I'm going to show it you tomorrow. I have to ask to get the radiographs. I have the clinical pictures of this lady. She will soon get a single crown then on top of this BLT 2.9. Okay, let me do the conclusions. And we will stop now then. I tried to show you that when we talk about the selection of implant type, this is very crucial for long-term success. Very crucial. Because these implants, first of all, should be documented by good studies so you know what you put in has high quality. Don't go for cheap copycat stuff and you have no clue. There is a study in Germany. They analyzed about 3 years ago 100 different implant brands concerning the quality of implant surface, how clean the surface is. 95% of the surfaces were contaminated. with ions of other metals, with even organic material, probably from the workers, skin remnants of people or so. So be very careful, stick to quality, to high quality companies who can produce top quality implants. Okay, they should have an excellent micrograph surface to improve the anchorage. Then we have a strong preference for tissue level implants in the bone because we have this hybrid design implants. Machine neck, micrograph implant surface to anchor the bone in the bone. Okay. And the bone level implants in the moment will limit to single tooth replacement. That might change when we get bone level implants with a machine neck, then we might increase the applications for that implant. So that's the future, we'll see. This will come. Okay, when you talk about implant diameter and implant length, so we say, don't give up diameter and length if it's not needed from an anatomic point of view or from a prosthetic point of view. So the anatomic point of view is the limitation when the crest is not right. Take a narrow diameter to improve your situation. That's clear. The prosthetic point of view, of course, that's the size of the gap. When the gap gets smaller, then you have to take smaller diameter to stay away from natural teeth. When we go for short implants, also then we use them only when there is a need for short implants. Don't go for short implants when you can place a 10 millimeter implant. Then don't give up the length. Anchoring surface is a very important aspect. When you go for short implants, please split them up in routine. There are only exceptions in very old patients when the chewing is not very strong. And the narrow diameter implant again is also dictated by the anatomy. So the 3.3, very often used, BLT 2.9, extremely rarely used, but then because it's very small gaps, most often in the anterior maxilla. So, okay, we go for lunch.